Steroid-refractory acute GvHD remains a major therapeutic challenge, but the approach today is much more structured than it used to be. The first step is to confirm true refractoriness, actually, meaning either progression after 3 to 5 days of adequate dose of corticosteroids or no clear improvement after 5 to 7 days, while excluding, of course, confounding factors such as infections, drug toxicity, or flare of the primary disease. And once a steroid-refractory acute GvHD is confirmed, treatment is guided by the patient's GvHD, I would say, phenotype, comorbidities, but also infectious risk. Ruxolitinib is the current standard of care after and based on the results from the REACH randomized trial. It has demonstrated superior overall response and durable control compared with best available therapy, and is now widely considered the first-line treatment in the steroid-refractory setting, acute GvHD. I would like to emphasize that optimizing supportive care during this process is essential. So we need to put in place early broad infectious prophylaxis, CMV monitoring, nutritional support, mucosal and skin care, but also a close management of fluid balance, because all of this often define outcomes as much as the immunosuppressive therapy itself. Now, if you have a patient who unfortunately did not respond to ruxolitinib or progressed after ruxolitinib, second-line treatment becomes more complicated. And we do have several options. ECP, extracorporeal photopheresis, can be considered, mainly, I would say, for skin predominant disease, but also when cytopenia limits other systemic therapies. Mesenchymal cells, mesenchymal stromal cells, the famous MSCs, are proving to be an important treatment option. And we have evidence pointing to benefit in selected cases, especially in the pediatric steroid-refractory acute GvHD. We do have also some emerging and targeted approaches that may rapidly change the landscape. There are some JAK inhibitors beyond ruxolitinib, some alpha-4 beta-7 integrin blockade, but most importantly, I think the microbiome, the microbiota modulating strategies, including FMT, fecal microbiota transplantation, or fecal microbiotherapy, it has shown some very promising and convincing efficacy based on different trials, especially the MAT13 product, which is a full ecosystem microbiota product. There are other options which are purely empirical, such as anti-IL-2 receptor monoclonal antibodies, anti-TNF agent, mTOR inhibition, anti-CD6 antibodies, but I would consider all of this at this stage being purely empirical. Of course, whenever possible, it would be good to refer these patients to and to consider clinical trials in a specialized center, given both the complexity and the evolving therapeutic landscape. So overall, the management philosophy has shifted recently from non-specific immunosuppression to precision-guided biology-driven therapy, optimizing, I would say, both disease control, but also the infectious safety. The cornerstone remains early identification, rapid initiation of treatment, and meticulous supportive care.